Okay, good morning, everyone. I want to thank you all for coming out this morning, and it's my great pleasure today to introduce Dr. Markle, who's visiting us here today from Northwestern University. And just to give you a little bit of background, Dr. Markle is the Lester B. and Francis T. Knight Professor of Cardiac Imaging at Northwestern in the Department of Radiology and Biomedical Engineering. And his background is he received his Ph.D. in physics from the University of Freiburg in Germany. And he served as a postdoctoral research fellow at Stanford University before being recruited back to Germany, to Freiburg, to be the director of their cardiovascular MRI imaging program. And then in 2011, he was recruited to Northwestern University in his current role, which is as the director of cardiovascular MRI research in the translational imaging section within Northwestern University's radiology department. So Dr. Markle, I think, is one of those individuals who really has done a fantastic job at advancing the field of cardiovascular MRI. And most of his work involves many different areas. He's got numerous publications. But I think what we're going to have him talk to you a little bit about today is about use of CMR for structure, function, and hemodynamics. And specifically, I think from the standpoint of hemodynamics, I think Dr. Markle has done some tremendous work at really doing some of the basic pulse sequence developments that we're going to be using, not today or not tomorrow, but rather things that we're going to be using 5-10 years from now. So I think he's going to show you some of the techniques that they've developed that are ready for prime time, but hopefully also show you where the future of cardiovascular MRI is. So please join me in welcoming Dr. Markle and give him a big round of applause.
Well, thank you. Thanks a lot for the introduction. Thanks for having me and giving me the opportunity to share some of our work with you, and good morning to everybody. Before I get started, just maybe a couple of words about Northwestern University. We are located really right downtown Chicago, next to the lake. Our campus is pretty much, I guess, a little bit similar to what you have here, kind of a downtown campus area with a lot of buildings all connected, probably not as big or as enormous as in Houston here. But again, we're kind of very integrated network of different hospitals downtown. And most importantly for my work, we do have an MR imaging core facility that focuses on different aspects of MR imaging research, neuroimaging, small animal imaging, molecular imaging, and cardiovascular imaging as well, which is directed by myself. So I'll talk today a little bit about our work that we've been doing in the past couple of years. And just as a very brief overview, so there's two main, I think, areas we work on. One is summarized as cardiac structure function imaging, where we try and use new MR imaging technology to better understand structural and functional abnormalities in the heart. And one focus here is, and I think that has become very popular over the past years, is really using quantitative imaging, kind of moving away from the qualitative reading of MR images where you look at hypo-intense or hyper-intense regions and compare those to other regions, rather than developing technologies that let you map out different structural and functional properties of the heart. Some of the key words here are T1 mapping, T2 mapping to assess left ventricular fibrosis and edema, or left ventricular imaging of left ventricular function, or perfusion, and come up with more quantitative metrics of cardiac structure or function, such as fibrosis, and how can that be related to regional functional abnormalities, such as reduced left ventricular velocity. So that's kind of a big focus area of us. And the second area that we've been working on, it was already mentioned in the introduction, is where we try and look at cardiovascular hemodynamics. And that's an area that can be summarized by the name of the technology that allows us to do that, and that's 4D flow MRI. And that's a technique that can be used to look and investigate and quantify 3D blood flow in different parts of the human body. I'm just showing three examples here, like intracranial blood flow in the left atrium and left heart. and also flow here in the thoracic aorta. This actually happens to be a patient after TAVI replacement. You can kind of see the flow is disrupted here due to an artifact of the valve, but nevertheless you can kind of map out the flow of velocity. And that's the area I'd like to concentrate on today and talk a little bit about how we can use this technique not only to, hopefully I'll be able to convince you to make pretty pictures like this that look nice and colorful, but how can we really use this information to learn more about disease progression and understand basic physiology of disease, and maybe also to better guide patient management. So let me just take a little step back and talk about what the technique really is. So what's 4D flow MRI? And it's really based on a technique that has been around since the 1980s or 1990s, and that's 2D phase contrast MRI. And that's a technique where you use MRI for the imaging of blood flow. And how it's typically used in a clinical setting, and you can do this on any scanner that's available commercially, is you place a 2D plane, for example here transecting the thoracic aorta, and you do a short measurement, typically done during a breath hold, and you get these types of images. So this shows you here, again, the section through the aorta, ascending aorta and descending. You can see measurement is synchronized with the cardiac cycle. You can see kind of the pulsatile motion of the ascending aorta and descending, a little bit of the pulmonary artery. And at the same time, you get the blood flow, underlying blood flow velocities with the same temporal and spatial resolution as the magnitude images. Here, this was a velocity encoding along the through plane direction. So white means flow is coming towards you. Black means flow is flowing away from you. So this kind of shows you the blood flow velocities in the ascending aorta and descending aorta. And the color coding or the grayscale coding here tells you that each grayscale value here is directly associated with the blood flow velocity. So the technique is quantitative. You can go in, for example, segment the ascending aorta and then quantify things like cardiac output, regurgitation volumes, peak velocities, and so on. So and this has been around for a long time. It's used clinically to assess, for example, aortic valve dysfunction, and so on. One of the disadvantages, of course, if you look at it, or if you think about the cardiovascular system in more detail, this is a 2D technique, and it only encodes velocity along a single direction. But if you think about the heart and the aorta here, it's a very complex integrated system where flow is going along 3 directions. It's kind of has a complex 3D geometry. So to really fully understand the underlying blood flow within the heart and surrounding vessels, you would need a 3D technique that encodes velocities along all 3 dimensions. And that's exactly what 4D flow MRI does. It's nothing else than just an extension of the traditional 2D phase contrast techniques to 3D coverage and 3-directional velocity encoding. So I'm showing an example here. So this is the same thing you've seen before. You have your anatomic or magnitude image here covering the aorta here, but now you have a full 3D coverage of the region of interest. And at the same time, we don't just use single directional velocity encoding, but we measure blood flow velocities along all 3 directions, like the Z direction, the Y direction, and the X direction. And these are the images as they come off the scanner. Of course, scan time is now much longer. Before that, for the last slide, we could do this in a single breath hold. Now we need to acquire data in 3D over the cardiac cycle with 3-directional velocity encoding. So this results in a much longer scan time. And that's kind of what initially hindered the application of that technique. Early implementation of that technique, it took about half an hour to acquire the data. You could kind of do this in a research setting with a very patient volunteer, but certainly not with a real patient. Through a number of developments, and I don't want to go into detail, but in particular optimal implementation of the pulse sequence, parallel imaging, imaging acceleration, we're now able to do this with kind of spatial resolution of maybe 2 to 3 millimeters, temporal resolution of 40 milliseconds, and in a scan time of anything between 5 and 15 minutes. And that kind of depends on the implementation, on the heart rate of the patient. There is some respiration control, and that needs to be done. But in a nutshell, it can be said you can now add it on to a clinical scan if you allow another, say, 10 minutes or so scan time. So still not where you want to be, but starts to become more feasible. So scanning is something that's now doable. And again, just want to point out why 4D flow MRI. So 4D, the name from the technique derives because we have a 3D volume over time. So 4D, and flow because we additionally acquired the 3-directional velocities. So the challenge now, if you look at this data, is that it's very difficult to understand. At least for me, with my brain, I can only always look at 2 images at the same time and never at 4 at the same time. So it's kind of difficult to understand the underlying content of the image. So the next challenge is, how do you make sense of that data? And there's a number of ways to do that, and I'll show a couple of examples. The first thing is you can do some kind of in vivo 3D blood flow visualization. So you can load these data into a 3D visualization package. First thing you can do is you can calculate a 3D angiogram from the data. And this is an example of a patient with a hypoplastic arch, and here a large aneurysm, proximal descending aorta. And then you can use 3D blood flow visualization techniques where you take those velocities that you've measured and use techniques such as time-resolved path lines and trace the measured blood flow velocities here through the aorta. And you can here nicely see there's flow going through the ascending aorta, then accelerates here through the hypoplastic arch, and you see this very large flow vortex here in this proximal descending aneurysm, and then some kind of helical flow down here. Color coding here is red for very high velocities and blue for slow velocities, so it's somewhat different than in echocardiography. But I think it shows you very nicely that this technique really allows you to visualize in 3D the blood flow velocities in the entire system. It also shows you that you can certainly pick up this very large flow vortex and the flow acceleration to the hypoplastic arch, which you may have expected, but you see additional features like these kind of helical flows down here or up here that you may have missed if you had just used the 2D technique. So I think it kind of shows you nicely that it allows you to really understand the systemic impact of a focal disease being the aneurysm, but you can really see how it impacts hemodynamics or flow really in the entire system here. I just want to make it very clear at this point before I go on. What you're looking at here, and it's often confused depending on the audience, is not the result of a numerical simulation or of computational fluid dynamics. It's the result of the measurement of the blood flow velocities in this particular patient. So we're not looking at a computer model or something like that. We're using visualization tools that are borrowed from this discipline, but we're really looking at measured blood flow velocities in this specific patient. So how is this useful? And it starts to become more useful, I think, if you start comparing really what's going on in a normal control. So this would be a 40 flow exam in a healthy control with a normal aorta. And you can see there's kind of very cohesive, organized flow with these parallel streamlines. And if you compare this here to a patient with a bicuspid aortic valve and a coarctation in the proximal descending aorta, you can really see that flow is substantially different. You have this kind of vertical flow, the range flow here, high flow acceleration here through this narrowing, and then really very kind of the range flow again here. So the idea then is, or the question is, can we use this to better understand is there a relationship between progression of disease or disease development and these flow features? Just want to point out again that the technique is quantitative. So you can use this type of visualizations. For example, here this is systolic streamlines to guide the eye where you're interested in flow patterns, but then really go into the data retrospectively. And again, this is the same patient as in the last slide, and interrogate, for example, peak velocities while you go through the stenotic region here on this side. So this, again, is one of the advantages of the techniques. Once you're done with the imaging, you can go to your workstation and analyze the data as much as you like, compared to a 2D technique where if you misplace an imaging slice at a certain location, you would have to bring back the patient to the scanner. But this technique, although the scan time is relatively long, has the advantage you deploy a 3D volume that covers the entire region of interest, and then you can go back retrospectively in the data and quantify at any location of interest. So I want to now move on and talk a little about how can we use this. And I'd like to focus on one particular disease, aortic dilatation and aneurysms, and particularly also on patients with bicuspid aortic valve, which is kind of the area where we have and other groups also have done a lot of work where I think we can show that there is actually quite some promises in this technique to go beyond the pretty pictures and actually come up with some numbers and hopefully also some risk stratification that might be helpful for these patients. So if you look at aneurysms, It's often tied to aortic valve abnormalities, and there's a number of things that kind of play together. It's kind of a complex disease. It's probably related to aortic geometry. There's aortic wall tissue abnormalities. There could be a genetic predisposition, as in Marfan syndrome. The expression or the phenotype of aortopathy is very heterogeneous, and it's kind of unclear what is the role of aortic hemodynamics or aortic blood flow in this case. And a particular aspect of that research has been the focus on aortic valve disease. It's actually very frequent, affects a large part of the US population, particularly bicuspid aortic valve, a congenital abnormality, affects 1 to 2% of the population, and that's kind of what I want to focus on today. And this bicuspid aortic valve, meaning an abnormal valve where two leaflets are fused, so you have this kind of narrowed opening of the valve, and that's very often associated with so-called BAV aortopathy, which is expressed as aortic dilatation and also additional valve abnormalities. But not all patients who have that bicuspid aortic valve develop this type of aortopathy. Only a select group of patients does. So the question is, why is that? Why is one patient group at a higher risk than the other one, although they have the same or very similar congenital abnormality? And there's kind of an ongoing debate on the origin of the aortopathy in those patients. And for a long time, and I think still to a large extent, it's believed that there's a genetic origin. There's a tissue degeneration that's inherent to that disease. So in addition to the abnormal valve, you have some kind of genetic aortic wall tissue abnormality that puts you at a higher risk for the development of that disease. The question we asked then, well, if this is the case, and if it's really genetic, why does not everybody get an aortic dilatation? So the question is, what's the role of hemodynamics? Maybe that valve changes blood flow in a specific way that promotes aortic dilatation. And since valves are probably not identical in each patient, maybe it changes the flow in one patient different as opposed to the other, and maybe that can help us better understand who is at risk of developing that disease. Or is it both? And I think it's likely both. I mean, it's been shown that there are some genetic abnormalities. There's no kind of one gene that has been identified, as in Marfan syndromes or a series of genes, but there's evidence. But hemodynamics, hopefully, as I'll convince you, certainly can play a role. And I'll just show this image to start out with. This is actually when we started working on bicuspid aortic valve, this is actually one of the early patients we looked at. And again, on the left side, you see a normal control, healthy control, with a tricuspid aortic valves, with 3 leaflets here fully opening. And on the right, you see a patient with a bicuspid aortic valve. You see kind of this typical fish mouth opening of the bicuspid aortic valve. And you can imagine if you compare this valve to this valve, it doesn't open as much. So it's a little bit like a narrowing. Although I want to point out this would be considered a normal bicuspid aortic valve. This patient does not have a stenosis or wouldn't be considered to have a stenotic valve. But nevertheless, if you look at the blood flow patterns, they're strikingly different. And in particular, you see this flow jet here exiting the valve and then hitting the wall here. And you may imagine that if that happens, like you're born with this valve, and this happens like 60 times every minute, 24 hours a day, throughout your entire life, you may imagine that, this flow jet hitting the wall may indeed kind of trigger that dilatation. So that got us interested really in this technique and say, is there really anything to it? Can we, identify those patients who have unfavorable flow patterns, for the lack of a better word at this point, and use that maybe for risk stratification or understand who develops disease and who doesn't. And in fact, there have been early studies, and this is one study from Mike Hope et al. At UCSF, where they actually have shown early on that if you look at just flow patterns, just visually grade those flow patterns and look at patients who have kind of eccentric streamlines or kind of deranged flow as opposed to those who haven't, they could find a moderate but significant association with progressive dilatation. Or in other words, those patients who had unfavorable flow patterns were more likely to have more severe progressive aortic dilatation compared to those who didn't. So this is kind of a nice piece of evidence that there may actually be something there that will allow you to risk stratify those patients in a better way. But this was a very small cohort, and the correlation wasn't very strong, so it's kind of an initial start, but it's not yet fully clear. The other confounding factor here, challenge, is that one bicuspid aortic valve is not like the other bicuspid aortic valve. They come in different flavors. In fact, if you look at the bicuspid valve or the congenitally abnormal valves, if you like, there's different kind of fusion patterns or valve phenotypes or morphologies. There's fusion patterns such as the right-left fusion pattern where these two leaflets are fused. There's the right non-fusion pattern. There's true bicuspids, unicuspid valves, or even quadricuspid valves. And all of those are geometrically somewhat different. The most frequent one is the right-left fusion pattern that you see most of the time, but there's also other patterns. So it means like they're similar, but they're built in differently into the aorta. And the idea is then, well, they probably also develop different types of flow patterns depending on how you build the valve in the aorta. And what's also known in bicuspid aortic valve patients is that the type of aortic dilatation or aortopathy can vary significantly between patients. There's different types of aortic dilatation patterns, type 0 being no dilatation, type 1 just the aortic root would be dilated, type 2 you would have a dilation of the root all the way up into the mid-ascending aorta, and type 3 you'd have a dilatation all the way up into the arch. And again the question is, why is that? Why does this patient only dilate here, whereas this patient dilates all the way up into the arch? If it's only a genetic abnormality, wouldn't you expect that it's the same in all patients? So what's the missing link there? What's the physiology? How do those patterns relate to each other? And then again, one of the answers could be flow, and this is a study we did some time ago where we're fortunate enough really to capture all these different type of valves. Again, we have the right-left, most frequent morphology, right non-fusion pattern, a quadricuspid valve, unicuspid, and a control. And you can map out these different flow patterns. And without going into too much detail, the point I want to make here is really that these flow patterns are very different between individual patients. They have common features. All of those have this kind of flow jet going through the kind of more narrow bicuspid aortic valve. But you can see the kind of vertical patterns and where this flow jet hits the wall are actually quite different. And this could be an explanation why you have these different dilatation patterns between different patients with different fusion patterns or different types of bicuspid aortic valves. And this actually has been recognized recently that this could be an interesting mechanism in a recent review article actually in the New England Journal of Medicine, where this kind of mechanism was proposed. And again, looking at the most common phenotypes of bicuspid aortic valves, the right-left fusion pattern, where these two leaflets are fused, and the right non-fusion pattern. So both of these valves are bicuspid, but they have different opening kind of geometries, if you like, and are built in differently in the aorta. And the idea is that this really results in this different flow jet patterns that impinge on different parts of the aortic wall. So the right-left kind of impinges on the right anterior wall and kind of results in a more type 2 aortopathy, whereas the right non-pattern has this more posterior outflow jet pattern, and then this would be explaining why you see this type of pattern more in right non-patients. And that's actually the case. If you look at the literature, you'll find that there are studies that have just looked at these aortic dilatation patterns. They found that this type of dilatation is more likely to be found in patients with this type of fusion pattern, whereas this type of dilatation is more likely to be found here. So there seems to be some indirect evidence now that links BAV morphology with outflow pattern and type of aortopathy that you see in this individual patient. The next question then you probably want to ask is, so these flow patterns are kind of nice maybe to look at, and there seems to be this link between the flow pattern and the dilatation, but how do you put a number to it? I mean, looking at these patterns can be challenging. How do you grade them? How can you come up with a better way of quantifying that? And again, just want to reiterate, also in a larger study, we saw that if we care controls to right, left, and right non-fusion pattern, we see consistently different fusion pattern, and those were in agreement with finding these different types of aortopathies. But again, how do you quantify it? And one way we started to look at it is look at wall shear stress that we can derive from the flow patterns. So what we can do is we measure the 3D blood flow in the aorta. So at any location in the aorta, we can look at the flow profile. And it turns out that the gradient, the velocity gradient along the wall is directly proportional. It can be used to quantify wall shear stress. Wall shear stress is the drag force along the endothelium. It kind of tells you how the flow kind of interacts with the endothelium. What's important here, there's a process called mechanotransduction, and that means wall shear stress can regulate endothelial cell biology, gene expression, and function. So it's not really a force that directly impacts on the wall, but it changes endothelial cell biology. So it means if you expose endothelial cells to normal shear stress, they kind of, the cells align with the flow, but if there's abnormal wall shear stress, they can have a disruptive effect. It can change their protein expression and so on, and result in a vascular remodeling. There have been a lot of in vitro and animal studies that have proven that there's a direct relationship between changes in flow, changes in local shear stress, that changes endothelial cell function and can lead to remodeling. So this, or in other words, the wall shear stress is a quantitative metric that tells you how changes in flow impacts the wall shear forces at the aortic wall. And the question we were asking, can we use that to quantify shear stress in these patients? And maybe this gives us a better quantitative handle on what's going on and how we can understand how flow may change the development of this type of disease. This is an early study we did where we actually did this wall shear stress quantification in individual 2D analysis planes, as shown here. So again, flow goes through here. This is again a patient with a bicuspid aortic valve. And here we then mapped out the wall shear stress along the vessel circumference. So this will be kind of the left, right, anterior, posterior side. And we compared a patient with a right-left fusion pattern here in this blue color and to age and aorta size matched controls. And you can clearly see that there's a significantly elevated wall shear stress in those patients with bicuspid aortic valve, and it's also kind of asymmetric, which also makes sense because you have these flow jets hitting the walls. You kind of have an asymmetric exposure to these wall shear forces. So this at least does not yet explain the disease progression or the different phenotypes, but it shows you that we can actually quantify wall shear stress, and that we're sensitive enough to detect significant differences between normal subjects and patients with bicuspid aortic valve. As a next step, we took this further and went from the 2D calculations, which can be challenging. Again, you have a 3D imaging technique, and then you're going back to a 2D analysis, so you probably want to utilize your full potential of the technique and do a wall shear stress quantification in 3D. So we went in and developed techniques where we can segment out the aorta. Here will be a control and a bicuspid aortic valve patient, and can then calculate 3D wall shear stress vector fields along the wall. Wall shear stress is a vector, and from that we can then kind of calculate the 3D wall shear stress maps. This will be the systolic wall shear stress magnitude here, and can go in different regions of interest and calculate and quantify wall shear stress. So this gives us a nice tool to really map out the impact of changes of flow on the aortic wall. First thing, however, what you need to do is you need to understand what's normal. What's the normal wall shear stress if you want to look at abnormalities. So one thing we did is we started to come up with a normal wall shear stress map, or kind of a wall shear stress atlas that shows us what's a normal wall shear stress distribution in a reference population. In order to do that, however, you need to kind of map one aorta onto the other, and that's exactly what we did. So we can calculate these wall shear stress maps. We did this in a series of healthy controls, and we found the most common aortic geometry in those controls by registering the aortas onto each other. And we can then interpolate the shear stress in the individual volunteer or control on the shared geometry, and then get a kind of registered wall shear stress map onto a geometry that's common to all people. And we can do this, for example, for 10 different volunteers. They all have somewhat different wall shear stress. We can then average it and then come up with something like a cohort average wall shear stress distribution, normal wall shear stress distribution, or a wall shear stress atlas. And this happens to be the wall shear stress atlas for a group of 10 controls in the age range between 41 and 50 years. So you can now at least have a better understanding what's normal. What's important to recognize here is that it's critical to age match that control atlas to patients. This is results from a recent study where we looked at these wall shear stress atlases for different age groups from 19 to 30, 30 to 40, and so on, all the way up to 60. And you can see there's actually substantial changes with increasing age in the regional distribution and also the magnitude of the wall shear. So I don't want to go into detail here. I just want to make the point that if you want to understand what's abnormal in a patient, it's very critical that there's an age matching process involved in your analysis. So we can now actually take those wall shear stress atlases and try and better understand in a larger cohort what's going on with patients with bicuspid aortic valve. And again, we're looking now at patients with different fusion patterns. This will be this right-left fusion pattern again and the right non-fusion pattern. This is the normal control wall shear stress atlas, kind of the normal reference. And we can then also do the same process and generate cohort average wall shear stress maps of these patients with right-left BAV fusion patterns and patients with right non-fusion patterns. And you can see the wall shear stress is very different compared to the control, but it's also very different between those patients with right non and right left fusion pattern, what we saw earlier. And now that you register all those shear stresses on the same geometry, you can also do direct statistical comparisons and come up with p-value maps that tell you where the local shear stress is really significantly different to your population average. Here for, again, patients with this right-left fusion pattern and this right non-fusion pattern. And you can again see that you have a very different expression of shear stress between those two patients. And if you go back, this actually corresponds quite nicely to the phenotypical expression of aortopathy in these patients. Again, right-left express more the type 2 aortopathy that's more confined to the root and ascending, whereas these right non-patients have aortic dilatations pattern that extend all the way kind of in the arch. And you can see that the high shear stress here is more kind of in the arch region, where here it extends more down into the root. So this kind of, again, ties it together nicely, that you actually see this correspondence of the way the disease develops and the way the flow is changed in those patients. And this is very recent results in our largest cohort so far with 312 subjects, 256 BAV patients and 56 controls that kind of reiterate those findings, where you see these very different wall shear stress expressions in those patients with different fusion patterns, here again corresponding to these typical dilatation patterns. One important note here, and that's we found that kind of interesting, is those are, for the lack of a better word, normal BAV patients, so they don't have any stenosis or aortic insufficiency. If you look at patients who have stenosis, then the flow patterns again change substantially due to the stenosis, and that kind of masks these underlying differences in shear. Or in other words, once the patient gets a stenosis, the fusion patterns become less relevant. So this might be also interesting to further investigate and better understand at what point an intervention might be necessary or how the disease develops. So again, this is a nice tool that helped us better understand on a kind of cohort average-based way to understand how flow can impact wall shear stress, something we can quantify, and how is that related to disease development. The other question you may then want to ask is, so what does this mean for the individual patient? We've looked at average over 80 patients and controls, but what does it mean one BAV patient comes in, he has a certain shear stress patterns, how can I learn something from that? What does that mean? How do I deal with the individual patient? And one kind of workflow we suggest here is that we calculate or come up with so-called wall shear stress heat maps. So this will be a bicuspid aortic valve patient with a very distorted aortic geometry already. And you can calculate, as for every of those patients, this 3D wall shear stress heat map, and this will be the aortic geometry. The next thing then is we pick our population average normal wall shear stress atlas, and we register this atlas to this geometry. And we can then directly compare on the patient geometry the wall shear stress on the patient to the normal wall shear stress atlas, and map out those regions that are 2 standard deviations above or below the normal population average. So you get then these regions that are wall shear stress hot and wall shear stress cold. So in the individual patient, you would now know, oh, there's regions here and here that correspond to high abnormal shear stress, and there's regions here in blue that correspond to very low shear stress, 2 standard deviation outside the normal range. And this actually gives us the opportunity now to better understand what's really going on with the tissue in the individual patient. So if we take one step back and look at what bicuspid aortopathy, or what this disease really is, it is really a disease of the aortic media, and it results in a medial degradation and fragmentation of the bicuspid aortic wall. So you kind of have this disintegration of the elastin fiber structure here, and you have different protein expressions and so on. And there's been a lot of work that went into this. Well, if you look at the kind of normal media and the extracellular matrix, you have kind of an organized layers of elastin and collagen, and that's kind of disrupted in the development of aortopathy in those patients. So you have an elastin degradation and thinning, and at the same time it's understood that there's different protein activity, and particularly MMP changes, and then there's also different TGF-beta signaling that's considered pro-fibrotic in these patients. So the disease, really the underlying disease, is a disintegration of the aortic wall here. And now with these kind of individualized patient heat maps that tell us or allow us to map out regions with, say, abnormal wall shear stress, we can actually start looking at these regions in more detail. And this is one of the most recent studies that were done in this regard, where we take a preoperative patient, a bicuspid aortic valve patient, who is already severely dilated and who will undergo aortic valve repair. And as part of the aortic valve repair, part of the aorta will be resected and replaced by a graft. So during surgery and aortic repair, the surgeons resect the tissues at different locations in the aorta, and that tissue would then undergo histopathology analysis. The protein profile was analyzed, and there was also some biomechanical testing. So I just want to point out this was actually quite a major logistic effort that required the cooperation of a lot of people, and it also involves researchers from the University of Calgary, and I particularly want to point out Paul Fedak and David Gussardi, who kind of headed the study in conjunction with us. So this was really a large effort to identify these patients, have the tissue resected, have it frozen, sent for analysis. We had to make sure the patient gets the 4D flow scan prior to surgery, and so on. Nevertheless, it gave us in this initial study 20 patients where we could now really test this hypothesis that if there is deranged flow, if we find these hot regions of shear stress, is this really related with a valve-mediated change in aortic wall degeneration? In other words, in each patient we could pick a wall shear stress hot region and compare it to a wall shear stress cold region. So each patient is really its own control. And if our hypothesis is correct, if wall shear stress really drives this aortic remodeling, we should find more degenerated tissue in those regions with high shear stress compared to those with low shear stress. And that's indeed what we found. So this is one example of a patient, tissue taken from a wall shear stress normal area. You can kind of see in the elastin kind of fibers here, and this is kind of a region with elevated shear stress. You can see it's more disintegrated, less elastin, thinner fibers, greater interfiber distances, which kind of is indicative for a kind of a disrupted aortic wall. This was similar for a different patient, just showing 3 patients here, regions with normal shear stress, elevated shear stress. They all look different, but you can see if you compare left to right, the fiber distances increase. It appears more disorganized. And this was also found on a cohort average basis. So fiber distance was significantly increased in those regions with high shear stress. Fiber thickness was reduced. The shear modulus, kind of a measure of the elastic properties or integrity of the tissue, was also significantly increased, pointing towards higher tissue stiffness. At the same time, we looked at a lot of protein profiles, and this is a little bit of a complicated slide, I apologize, but what this shows is really kind of maps out these data points here showing everything above this line shows patients were in regions with elevated wall shear stress. We found increased activity of a particular protein, and here we found decreased activity. And you can see that these MMPs are almost, in all cases, kind of overexpressed kind of in these regions with high wall shear stress, which again indicates that there seems to be a correlation between higher shear stress and differences in protein activity in these regions. So as a kind of brief intermediate or a summary is, if I want to go back to the beginning of my talk, I hope you believe me that we can use 4D flow MRI to really measure in vivo flow and quantify shear stress. Do flow patterns matter for aortic disease? I think we could show that aortic dilatation of valve disease is very clearly associated with eccentric outflow jet patterns. We could show that the difference in those flow patterns, as quantified by wall shear stress, were kind of associated with the expression of disease. And more recently, there was kind of more direct evidence that the altered shear stress is really linked to histology or changes in aortic wall architecture, biomechanics, and extracellular matrix function. So we believe that hemodynamics actually could be a contributing factor to the physiologic mechanism for disease development. Just want to give you two more slides on where we think this should go in the future direction. So we've shown this association, but what's of course desperately needed is really also longitudinal studies. So you want to understand if you have this kind of hot regions of shear, how do those regions affect the development over time? We started to look at that. We have now a couple of patients where we have 1 and 2 year follow-ups, but at this point we don't see much changes, and this is just one example here. So this is a patient at baseline. We kind of see these wall shear stress hot regions, and then about a year later, and you see it didn't really change, but in this case also the aortic diameters didn't change much. And that's probably to be expected. If you look at the literature, you probably have to wait 5 to 10 years until you see significant changes in aortic dilatation. What's nice about this, and why I like to show it, is that these patterns seems to be very stable. If there's no changes in geometry. So at least it tells us we're not just measuring random noise, but we seem to have a metric that's at least stable over time, and that seems to be reliable to map out these high regions even after 1 year, the patient coming back. So that's one thing. I think there needs to be much more work in terms of longitudinal study. Unfortunately, it will take a longer time to get all that data. And secondly, what we thought was interesting, and this is more the cardiac surgery approach here, is can we maybe use these maps for better individualized kind of risk stratification or surgical guidance? Currently, surgery is indicated merely based on diameter. If it's 5.5 centimeters or above, or if the growth rate is more like half a centimeter per year, then typically that's intervened. But if you think about the disease, there's this heterogeneous expression of aortopathy, and then there's also this very different shear stress maps. And this is just an observational study where we looked at the pre-surgical heat maps and then looked at the region that was actually taken by the surgeon during aortic repair. And you can see there's some patients where all the shear stress regions are taken out, but there's others where those regions remain. So the question is, maybe this could guide resection strategies in a better way to make sure to remove all the tissue that has been exposed to shear stress. Or maybe that's not necessary. That will also require longer longitudinal studies. But I think there's an opportunity to better understand the individual risk and maybe even use that information to guide resection strategies in those patients. And with that, I come to the end. Again, I want to thank Deepan for inviting me here, to giving me the opportunity to present some of our results. I'd like to acknowledge my funding, and of course, thank you very much for your attention.
Thank you, Michael. That was an outstanding presentation. We've got some time for questions, and let me just start off with one. I think you've done a really nice job at showing us taking kind of basic MRI techniques and using that to try to help kind of improve our understanding of physiology and pathophysiology. Now, have you done any work where you apply this now to different pharmacologic therapies? So let's say patients with bicuspid valve, what happens to their wall shear stress when you give beta blockers or ACE inhibitors? Do you have anything on that?
So that's a great question. So we started to look at patients with bicuspid aortic valve on beta blockers and not on beta blockers. And surprisingly, we really didn't find any difference in the wall shear stress. I mean, you would kind of expect that it's different, but we didn't see it. But the challenge was that our first study, we just compared two cohorts that were age and gender matched, but we didn't look at patients who were off beta blockers and then went on beta blockers, which would be the ideal study. We're starting to do that, but we only have about 5-10 patients. It's kind of tough to recruit those patients who are off beta blockers before they go on to any type of medication and then compare that. So at this point, I would say it's inconclusive, but I think it's a great question. You could even drive that further and see, can you maybe better understand the impact of dose? Right. Or maybe you're dosing beta blockers much too high. If your goal is to reduce shear stress, maybe you could do away with half the dose, or another patient may benefit from a higher dose. So it's a great question, but we don't have very good data at this point.
Okay, great. Huey? Or, I'm sorry, Dale.
Yeah, thank you. Very nice presentation. And in my field, we study metabolism in myocardium when it's under stress. And we're looking at using PET to quantitate uptake of C11 and F18 compounds. But we need myocardial blood flow. Can the 4D flow MRI be used to calculate or quantitate coronary blood flow, myocardial coronary flow, so we can calculate extraction of these compounds, as opposed to, say, using O15?
So that's a great question. So you're asking, can we measure coronary blood flow? The answer is not at this point, and simply because we're really limited by spatial resolution and temporal resolution. I mean, as you know, coronary arteries are probably the most challenging to image. They're small, they move around a lot during the cardiac cycle. So we and others have tried, and there's a great interest to be able to do this, but at this point with the techniques we have, it's very difficult and very challenging to get reliable data on the coronaries. Would be great though, but it will require more technology development to get to that point. But it's a great question, yeah.
Okay, Huey?
Great, awesome presentation. So we are really interested in looking at changes in 4D flow patterns in the right ventricle in congenital heart patients. But the struggle that we have had is that we're always looking at them sort of as a snapshot, and oftentimes when they've already developed pathology. So one of the things that struck me about the aortic pathology area is, do you have data from patients who have not yet developed changes in their aortic anatomy? Because I think that's where it becomes very interesting, right? Because if there's already a change in the aortic anatomy, is it the chicken or the egg? Is the change in the anatomy first, or is it the wall shear stress changes that are first?
So again, that's a great question. So I haven't answered the question, is it a genetic or hemodynamic origin? It's probably both, but the question is what comes first. My theory is there is a genetic abnormality, but it's probably less or more severe in different patients. And if it's combined with a specific flow pattern, it just enhances kind of the development of the disease. There is one study out of Munich that has looked at pediatric BAV patients or young BAV patients prior to the onset of aortic dilatation with bicuspid aortic valves. And they actually did find changes in flow pattern in those patients compared to controls, but they haven't followed up those patients. Or at least I haven't seen any publication yet. But again, I mean, this will be the best study to do. I mean, start early on when there's no dilatation and then look at the patients 10, 20 years later to understand who has really developed that dilatation and can you tie it to a specific flow pattern.
Do they see the same changes in wall shear stress even before they develop?
Similar, yeah.
Yeah. Bill?
Really enjoyed your talk. I think it has great potential applications in so many diseases too. Question to you, have you had any experience with other pathology of the aorta, meaning a couple of things. One, Marfan. Two, aortic stenosis, with a post-stenotic dilatation that's usually, assumed to be because of vortices, etc. What is the wall shear stress like?
Yeah,
and does it predict that?
Again, great question. So I'll start with Marfan syndrome. We actually have looked at that. And Marfan patients are very different to bicuspid aortic valve patients. First of all, they have a tricuspid aortic valve typically. And what you find in Marfan patients, you actually find typically areas with reduced wall shear stress in those patients. So they have more sluggish flow. They dilate earlier. They don't typically have this kind of stenotic outflow pattern, so you don't see these flow jets. So you have more kind of deranged vertical flow regions with low shear stress. Low shear stress has also been shown to be implicated in vascular remodeling. So my understanding is shear is like, as long as it's kind of on a medium level and constant, it's good. If it's too high, it's bad. If it's too low, it's bad. Marfan seems to be a different disease process, but with Marfan's, I think it's also much better understood that it's a genetic abnormality and a connective tissue disease. So there's a more clear kind of origin of the disease. So we've looked at that. We've seen that the flow patterns are very different. It's more reduced shear. Interesting, what we found is that particularly in the proximal descending aorta in a subset of Marfan patients, there seem to be very pronounced vertical flow patterns in regions with low shear stress. And that's where a lot of the dissections are happening in those patients in the descending aorta. So there seems to be an indication that flow may help there to identify those patients who may be at a higher risk for aortic dissections. And then the second question about aortic stenosis. That's a kind of difficult population to analyze because you have these very high flow velocities, and anything that's going on underlying the stenosis, like a bicuspid aortic valve or some other disease, is masked almost by the very high flow of the stenosis because it introduces such high shear stress values and such kind of deranged flows that it's sometimes difficult to tease out what the true origin is of the disease. Once you have a stenosis, I think it almost overrides everything else.
So, in the thinking of the natural history, I know you alluded to, obviously, you need more time to figure this one out. As the aorta dilates, do you think wall shear stress will decrease for the same flow?
Yeah, so that's a great question. I think the aorta tries to dilate to decrease the wall shear stress. But if at the same time the aortic stenosis worsens, then I think it's a compensatory mechanism to kind of get rid of the high flow and the high shear stress. So it remains to be seen. We don't have the data yet. I would assume that you get change in these shear stress patterns, but you don't, for bicuspid aortic valve stenosis, you don't get rid of that flow jet. It will be redirected in different ways, so you probably shift around your shear stress regions. I think as soon as it starts and as soon as you have these high shear stress regions, it's almost too late. You probably won't get rid of it entirely. The question more is like, when do you want to intervene? And is that 5.5 centimeter threshold really appropriate? Or do you want to be more individualized and look at the, say, individual patient shear stress patterns in conjunction with other metrics and decide on the intervention based on that data rather than looking at those empirical thresholds that we have today?
When you're seeing the flow and the flow related to the blood ejected to the aorta, are you able to analyze the relationship between the mechanical properties of the aortic wall itself with the flow? Or because I see when you put the 40 flow, kind of the image is still. And there's any way you can analyze the dynamic of the reflect wave of the aorta? And I think that may be useful for older patients.
Yeah, so that's a great question. So what we've looked at it as wall shear stress, which is not a mechanical property of the wall. You're probably more interested in wall stress or elasticity compliance of the aorta. So there is ways to look at that. One way is to estimate pulse wave velocity, for example, from the 40 flow data. Has been done. It's kind of challenging because you need a very high temporal resolution to be able to do that. You could use other MRI tools to look at vascular compliance or at mechanical properties. But that's very difficult to do simply because it's the spatial resolution you need to measure the aortic wall. It's very thin. Or the high temporal resolution for the pulse wave velocity. There's works in progress, and I agree with you. It would be ideal if you had the whole package and could understand this is the shear stress, this is the mechanical property of the wall, this is our elasticity index, ideally regional, and that this would give you a much better picture. I agree.
Okay, Irvin?
Yep. Thank you for that fascinating talk, and we believe MRI is everything based on what Dipin tells us, so we definitely
I can only
trust it. But if I noticed it right, in your age control atlas that you had, there's less red in the aged people. So there's less stress because of remodeling. Is that because of thickening of the aorta over a period of
I think, yeah, it relates
time?
back to the question that was asked. So you have a kind of natural dilatation when you go older. So and you make the vessel a little bit larger and you keep the flow the same. This will kind of change the velocity profile and gradually reduce the shear stress while you age. This is I would think of this as a normal aging process. So your flow velocities become lower, your aorta dilates a little bit. Maybe you also reduce your ejection fraction a little bit, and all that taken together will reduce peak velocities, flow velocities in general, and also the shear stress in a normal population. Yeah.
I mean, I think that's fascinating for population studies, for you to pick the age of intervention for anything, hypertension versus controlling the stress in the aorta between 19 to 30. Because if you already have the pathological changes, because I guess you need to validate the pathological changes as you age, and if you have higher stress early on and you intervene, maybe you'll decrease the pathological change.
Okay. Okay, and then are there any questions from the satellite hospitals? Okay, if not, I want to thank you all for coming out and thank Dr. Markle for an outstanding presentation.